Hi, Dr.
How are you
Michael.
doing?
Good, how are you?
I'm doing okay. How are you doing?
Can't complain. I like your background of books.
I changed it around a little bit, so that
Look
might actually be fine. So hopefully things will make it a little bit easier and more entertaining. So
awesome. Um, well, I'm very excited to talk about endometriosis. So March is Endometriosis Awareness Month. And I think there's so little known about these. So, I'm happy to have you here to educate everyone on what it is, what the symptoms are, how it can impact fertility, and all of that good stuff. So, I guess we can start by just going into what is endometriosis.
okay, that's an easy, well, not quite an easy question, but at least one that we can kind of jump into to answer. Endometriosis is a condition where the tissue that's outside, that's usually inside the uterus, forming the lining of the uterus, then basically attaches in and is outside the uterus. It can attach to the ovaries, to the fallopian tubes, to the rest of the peritoneal cavity. In rare occasions, it can actually travel through the bloodstream and actually, go into the lungs or other areas. Those are pretty rare. So typically, when patients are talking about endometriosis, they're talking about more localized disease where it's in the pelvis itself.
Mhm.
Some of the symptoms that patients may have is first, not all patients are symptomatic, and that's important to kind of realize and to know. So many people may be walking around with endometriosis and not know it at all. How sometimes patients will actually at least get some symptoms would be if they have pain with their menstrual cycles.
Mhm.
And patients vary, so therefore some people might end up having minimal pain but have severe disease. Others might actually have really minimal disease and have a lot of pain. So it's all going to be relative. But the disease comes from the stimulation of these abnormal areas outside the uterus that then reacts to menstrual flow, menstrual blood. So when you're having your period, when you're trying to shed that lining, those areas are also bleeding into those implants, and that's what causes the irritation. That's what causes the pain. Sometimes patient will actually have pain within a course. Sometimes patient will have pain with, either going to the bathroom to urinate or to have a bowel movement. So that's how sometimes patients will present with endometriosis.
Okay, that's so interesting how the severity of the disease doesn't necessarily correlate with the amount of pain
Mhm.
experienced.
That's always a question because you'd imagine that someone who has really, really bad disease would then end up having lots of pain. But, we've seen patients who have pretty significant, pretty advanced disease where you end up having bowel obstruction. And that's how they present because, the endometriosis has gotten so bad that it infiltrates the lining of the intestines and then causes obstruction. And those patients don't have pain. So those are not as common, but something you can see. One of the things that is also important to realize is just that, even young patients, teenagers can have endometriosis. So you can't ignore young women who have that cycling pattern when they're actually just starting out their menstrual cycle to say that they don't have endometriosis.
Right. So how do you diagnose it? And I know there are different stages. How do you diagnose each stage?
Well, the only way to truly diagnose endometriosis is laparoscopically. There are things that you can do to indirectly assess whether someone has endometriosis by doing pelvic ultrasound. And what you might see is you might see either endometriomas, those abnormal areas inside the ovaries. They can grow to a pretty big size. And that's typically how you'll diagnose them without surgery. It's very hard to diagnose ones that are involving like the bladder or the bowel without surgery because you're not going to be able to see those implants.
Okay. So is surgery, we did get a lot of questions about that. Is surgery always necessary to diagnose, or even to treat, to get pregnant?
Well, diagnose, treat, and getting pregnant are three different buckets. So I mean, I'll walk through them separately. Sometimes what you'll do is, someone actually has symptoms and we might say you have a presumed diagnosis of endometriosis, and then what we'll do is to basically outline a plan based on what that patient's goal would be. If the patient's goal is primarily to manage pain or manage your menstrual cycles, then we might actually say the thing to do is to not do surgery, not try to basically do anything invasive, and simply treat that patient, symptomatically. And the reason to do that is just that every time you have surgery, you then add several different factors. One, you can actually add risk of having scar tissue, your risk of actually having other things develop. So you want to try to minimize the number of surgeries you do, especially if the patient haven't started their family or is not completed their family, because it involves risk in terms of removing eggs. And as a fertility specialist, one of the things that we're very concerned about is anything that's going to allow them to reduce their chances in terms of getting pregnant.
Yeah. Okay. So you mentioned pain. How can someone with endometriosis, whether they know they have it or not, sort of manage that pain? And someone actually mentioned, could fertility hormones like IVF meds actually contribute to the pain or exacerbate it in any way?
Again, two different questions, but yes, you can. And I'll walk you through how you manage the pain first, and then also how fertility medications, how fertility treatment may worsen that pain. So if you looked back in the early, say, 50s and 60s, when they started diagnosing endometriosis, what they did was they realized that women with endometriosis would feel better when they got pregnant. So therefore, you can't tell everyone that they're going to just need to get pregnant all the time, because then, they would feel better. And sometimes you'd end up having some improvement in their pain after they're delivered to last for a long period of time. So what they started to do was to develop these medications, these situations where you'd end up having a pseudo pregnancy. Birth control pills is a way to kind of do that. So what you can do is to put someone on continuous birth control pills, not have a break in that pattern, and then that actually acts the same way that pregnancy would, in terms of quote unquote burning out the endometrial implants. How it does that is it stimulates those areas that are outside the uterus to continue to proliferate, and because those are encapsulated, it basically causes the cells inside to die, and then that's how it's presumed that they actually burn itself out. And so if you had surgery before and after those events, you'd end up seeing that patients who had those implants, you'd end up having these dark areas that actually just kind of looked like, the tissue was dead. And so that was one way in terms of doing that. Going through IVF, what happens is just that IVF, the medicines and everything else, stimulates the production of estrogen. Estrogen is what actually stimulates those implants to grow. And because in an IVF cycle, you're not going through a prolonged stimulation, all you're doing is increasing the hormone levels for a short period of time, that's going to cause those implants to grow. And then when you stop those hormones, it's going to cause those to then cause a lot of pain. So yes, patients will end up having a lot more pain when they actually go through the cycle. Getting pregnant on the other side of that, which is the goal of IVF, those patients will end up having relief afterwards. So that's an improvement. But again, that transition, that discomfort is something they're going to feel.
Okay. So if a patient comes to you with endometriosis knowing that they have it, what would your kind of treatment protocol be? Would it be go straight to IVF, or do you typically try IUIs with endo patients?
Well, I think it depends on a lot of things. It depends on things we talked about earlier in previous events in terms of their ovarian reserve. So someone who is young with a good ovarian reserve, they can try, less aggressive measures. They may even try surgery first, because, there's a number of reports that show that women with mild endometriosis, even moderate endometriosis, if you did surgery and reduced the implants then, and then they got pregnant within that first 6 months to a year afterwards, number one, they had an easier time getting pregnant. and getting pregnant treats the disease. So therefore, that's a better way for them to sort of manage the symptoms. So someone who is young with good ovarian reserve, you might say, well, surgery is a good way to go. That will actually allow them to be treated. Still, it's not a guarantee, so therefore you'll end up having some women who, even with surgery, they're not going to get pregnant, and then they'll actually have to move on to more aggressive measures and going on to IVF. One question you asked earlier is how do you stage endometriosis? And, that has a lot to do with, where the endometriosis is located within the pelvis and, what other organ structures are involved. So if it's simply limited to the ovaries and nothing else, and then there's a minimal amount of adhesions, you might consider that, grade 1. If it's basically having involvement to the fallopian tubes and also what we call the ovaries themselves, that may be grade 2. If it involves the adnexa, meaning the intestines, the bowel, then that's going on to grades 3 and 4. And sometimes you'll end up having it where it basically encapsulates everything, and that's actually stage 4 disease with significant impact. So those are the different stages you can see.
Okay. And do the different stages of endometriosis contribute to a higher risk of pregnancy loss?
Pregnancy, endometriosis itself may not interfere with pregnancy loss. It may interfere with the chances in terms of getting pregnant because they're treated. And also because endometriosis is an infiltrative disease and it actually may reduce the egg number by basically just infiltrating the ovary itself and having fewer eggs to begin with, it may impact not getting pregnant or keeping the pregnancy. Well, actually, it may impact not keeping the pregnancy because what will happen is just that patients will ovulate, the endometriotic implants will basically, for lack of a better term, kill the sperm or kill the egg interaction, so they just don't get pregnant that way. IVF bypasses that, so therefore, you can actually do is to go through IVF. Endometriosis typically doesn't involve the uterine cavity, so from that perspective, someone who has endometriosis and someone of the same age, if you're having the same, say, quality of embryo, their chance of success is going to be pretty similar. The thing that's different, if you compare those two individuals, say, women who are in their 30 and they end up having, endometriosis and the other one doesn't, the one without endometriosis will have more eggs, more embryos, and more choices. The women with endometriosis will have fewer eggs, fewer embryos, and the quality of those embryos may be different. So therefore, that's where that choice and that difference comes in. Not necessarily the age, but it simply just comes down to number. So therefore, that's the biggest difference. Still, not all women will actually have a reduction in their egg number. So if you have a woman with endometriosis who has a high egg number, you're now comparing it with somebody else, their chances of success are going to be pretty similar. And the chance of miscarriage is not going to be diminished by, it's not going to be increased because of endometriosis.
Okay, that's good to know. And then you did talk about some women who have like mild forms of the disease, or I've heard the term silent endometriosis,
Right.
where maybe they have unexplained infertility and then learn they actually had endometriosis. So what's your experience with that? Like, how have you diagnosed certain people with sort of underlying endometriosis where they had no symptoms and and it was just unexplained infertility?
Well, many a times you're actually doing it by ruling out other things. So they've been trying for a long period of time. You're doing ultrasound, you're not really seeing anything pretty specific on the ovary. You might do a hysterosalpingogram, a dye test to look and see if the tubes are affected, and that might be open. But sometimes what you'll see subtle things like in an ultrasound, the ovary doesn't move as easily compared to women, so therefore that suggests that there's some sort of scarring from the ovary to the uterus, and that's that subtle suggestion you might see. That patient may not have any pain, and so therefore those individuals may be better off going directly to IVF because those patients end up having silent disease that are actually affecting, the implantation and or the fertilization of those embryos, or the eggs themselves. So therefore, that may be the factor. Or the patient, depending on age, can try surgery first, but then again, you want to make sure that they have a timeline that if you're trying surgery as a first measure, you're getting pregnant within that first year, because after that first year, you may end up having a reduction in terms of eggs, quality, and everything else. So that's important to realize.
Okay. Interesting. Um, else. So as far as IVF goes, is there, you said IVF can kind of bypass some of the issues that with endometriosis sperm. What about implantation? Does that, like when you actually get embryos and you transfer them back into the uterus, can endometriosis affect implantation?
Not always. I'd say that, there is some suggestion that, patients with endometriosis may have a slightly lower chance of implantation. I think those data are not entirely convincing because, you're comparing women with, it's not simply just the quality of the embryos, it may be the genetics of the embryos, so therefore that's one factor.
Hmm.
But I think it comes down to basically having fewer eggs and fewer embryos to begin with rather than the endometriosis itself. There is some slight suggestion that patients will actually have not just endometriosis where it affects the outside, but adenomyosis that affects the uterus itself. And those women will end up having a reduced chance in terms of implantation, an increased chance of miscarriage, because they have both disease, and therefore that's a symptom that they'll end up having. And that causes, a greater degree of problems, if you will.
So is that where scar tissue grows in the uterus?
Correct. So therefore, that's where those lining, those little defects, rather than simply going, if you can imagine, the uterus is in the muscle where the entire lining is within the inner part of the uterus. If those lining then basically burrow into the wall, into the myometrium of the uterus, then an embryo could get implanted into those areas and then basically don't have as much supply around that, and then basically you'll end up having reduction. Or, basically, in terms of trying naturally, you may not have a clear path for the egg or the embryo to grow, and so therefore that's how it diminishes that opportunity. So patients with adenomyosis, which is a different disease, but still something similar to endometriosis, will end up having a lower chance of basically getting pregnant and continuing the pregnancy, a higher chance of having complications with the pregnancy, and those are things you have to kind of manage and deal with.
Okay. Is that less common than endometriosis?
It's less common, and it's something that you might actually suspect because the uterus looks sort of what we call boggy, and the endometrial cavity isn't clearly as defined. MRI or magnetic resonance imaging of the uterus is a really good way to kind of basically distinguish and identify those people. That's also another way to kind of look at endometriosis itself as well.
Mhm.
But yeah, those are invasive ways, if you can, in terms of basically distinguishing those disease. So that's a thing that's different.
Okay. Do you ever use the Receptiva test to diagnose endometriosis? I know that's a fairly new technology.
That's actually one thing that's been fairly new, and it provided a great degree of promise for the non-invasive ways to tell endometriosis. And that actually comes from a group in North Carolina that actually identified these factors that are associated with endometriosis that are not just on the outside of the uterus, the inside of the uterus as well. And the premise goes back to one of the things you said in terms of those patients with endometriosis. If you end up having a patient who has, this implantation issue, and you're not sure what's actually going on, they may end up having mild endometriosis, but also adenomyosis. Doing the Receptiva DX testing will actually allow you to identify those individuals. And the way you would end up trying to manage those patients is putting them on Lupron for a long period of time to suppress those implants, and then planning the transfer after that period of time. And there's a number of reports to say those individuals who are tested do have improvement in terms of their chances for success.
Okay, awesome. We got a bunch of questions about like those who are kind of just seeing an OB at this point and just starting out trying to conceive. Do you have any tips if they know they have endometriosis? Is there anything they can do with like diet or lifestyle or supplements?
Unfortunately, there's not a lot that's known about specific diets that manage endometriosis. We know that patients with polycystic ovarian syndrome (PCOS) will end up having things that they can limit their glucose, limit carbohydrates, and manage things that way. And there's specific diets around that. Not so much with endometriosis. People have talked about using supplements that increase, the antioxidants as some improvement overall, but even that those are non-specific, and that may not entirely help patients with endometriosis. So from that perspective, there's not really a way to quote unquote have a specific diet to treat that disease or that disorder. I think the key thing in terms of patients who have known endometriosis is planning. And I think that's a big part of it. So if you're seeing your OB and they're saying, well, you have endometriosis and you've been trying, I would say that typically if you're under 35, people talk about trying for a year, and then 35 to say 38, trying for 6 months, and then after that, trying for 3 months. Patients with endometriosis, I'd probably say should start seeking help a lot earlier. And the reason for that is just that you need to basically be relatively aggressive. And it also comes down to how many children you're planning for in your family. So if you had a child before and you may end up you just want one more child, then you may end up, finding out what's going on, but not be as aggressive in terms of saying, well, this is what you're going to pursue to manage your treatment. However, if you're just starting out and, you want to basically preserve your opportunity, finding help and getting help sooner rather than later is going to help you in terms of managing a lot of the things for the near term and the long term. And that's the most important thing to realize. So going through procedures to either freeze eggs, because endometriosis, we know, is an infiltrative disease, and therefore it will reduce egg number over time. So those individuals might freeze eggs earlier if they know that they're not ready to start their families now, or creating embryos so they can actually then get pregnant at a later date. But those are the things you can kind of do, but simply doing nothing is probably not the best order to do.
Right. What are the chances, or is there an increased chance of success with donor eggs for endometriosis if you're really having trouble getting good quality eggs?
If you end up going through, say, with endometriosis, you found that it does cause severe it does affect the ovary severely, so you can't get a good number of eggs. Then egg donation is actually a perfect way in order to get pregnant successfully. Again, because endometriosis involves primarily the ovary and what goes on there, and if it reduces the egg number from the ovary, you can actually go through and not get any eggs, but the uterus works perfectly fine, so you can end up going through egg donation and having a great chance in terms of conceiving and having a family that way.
Awesome. I'm just looking at some of the other questions here. Let's see.
Well, one thing I can see is someone said, or was asking about surgeries. And the thing that happens is just that, let's say someone actually has, and I'll give a scenario that's, a good example. Someone in their 20s has severe disease, has an endometrioma, and therefore undergoes surgery and removes that endometrioma, and it's on their left ovary. Let's say it's a 5 or 6 centimeter endometrioma. That sounds really big. They end up having surgery and they remove that endometrioma, but they're also removing a good number of eggs that are attached to the wall of the endometrioma. So let's say, even if they're on birth control pills, now they're, say, 30, and they end up having another endometrioma in the other ovary. They go through a second surgery. They're not ready to have their family. They're not really, no one's ever talked to them about, freezing their eggs. So they go through a second surgery to remove that ovary, that endometrioma now from the right ovary. Now you end up having both ovaries that are affected that are going to then, over time produce fewer eggs. And so those patients may be impacted with end up having fewer eggs. Not only that, but you may end up having more scar tissue form from the surgery itself, not just from the endometriosis. So therefore, that's another factor you have to kind of basically, manage. So overall, the key thing is finding out when you need surgery, and some people do, some people will. There's no way around that. But importantly, the thing to do is to find out and make sure that your surgeon is going to be skilled to try to preserve as much normal tissue as possible and reduce a few scarring as possible, because that's what's going to help long term.
Okay. What's the difference between excision surgery and the laparoscopy? Is the last laparoscopy more diagnostic?
No, a laparoscopy can be operative where you're removing the endometrioma. So therefore, that's where you excise the endometrioma.
Oh, okay.
And patients with significant disease, you can even remove the entire ovary laparoscopically as well. The key thing is basically trying to, in patients with endometriosis, trying not to rupture that endometrioma so it leaks into the rest of the pelvis, because those implants can then leak everywhere, and then you can end up having endometriosis implants on other areas within the in the pelvis. So if it does break, what you want to do is to make sure you wash out all that tissue and get as much of it out as possible, and kind of manage things that way. And then, the other types of things to do with surgery are to put barriers to kind of prevent adhesions. Now, they're not always successful, so that's important to realize, and everyone's different. But the key thing is what you're trying to do is to make the area as normal as possible afterwards, and that's the important part of the process.
Okay. Can having a C-section exacerbate scar tissue related to endometriosis?
It doesn't necessarily exacerbate scar tissue, but we've actually had a number of patients who had endometriosis, had a C-section, and then ended up developing the issue where they ended up having implantation within the C-section scar. So someone who goes through, and then basically now, every time they have a period, their C-section scar starts to hurt, and then you'll end up you'll see that basically there are implants that are there. And those patients sometimes will need surgery to excise that scar, and you'll end up seeing endometriosis within the scar itself.
Okay, so those are people that already had endometriosis?
Correct. Right. So, so endometriosis isn't going to be caused by a cesarean section. So,
Okay.
no, that's it.
Let's see, what else do we have? A bunch of people are talking about receptiva, which is good. Um, it's crazy to me how you can have excision surgery and then what's like the window where it typically grows back? Like 6 months, you said?
Well, what we try to do is to say that, plan your surgery. So if you know you have endometriosis and, okay, and it's relatively small, there are different various, conditions to say what size that would be. And let's say even if you're having mild to moderate symptoms, and again, let's say you're not in a time when you're planning to have your family,
Mhm.
then what you might do is to do whatever you can to not do surgery, but go through some other measure to not promote the progression of the endometrioma. So going on birth control pills or going on different measures to kind of shrink the endometriomas may be something to do. People talk about using medicines like danazol. That's actually one of the medicines that's a much older medicine. It's an anti-estrogen that basically shrinks endometriomas. You don't see it used as often now because it does cause some changes within the liver, and you might end up having some benign tumors within the liver if you're taking it for long periods of time. So it's not as often used. And there are a number of different medicines that are online now that are oral type suppressants for estrogens that are used for treatment of endometriosis. So any of these measures are ways you can kind of manage the symptoms during the time when you're waiting, if you will. And
Mhm.
then, the key thing is, basically timing everything and properly intervening so you can kind of maximize your chance of success when you do plan to have your family.
Right. So it seems like planning is really key and advocating for yourself for any tests or, if you feel like something's wrong, just, get further testing or ask for further
I
testing.
think that's actually the best thing to think about. Advocating for yourself, understanding the disease. Basically, there are organizations that you can actually read about and end up having groups that basically will help you to advocate for yourself about endometriosis. So therefore, that's important to kind of realize,
Mhm.
and be knowledgeable about the disease. The last thing you want to end up doing is end up actually having this happen to you, ignoring it, and then finding out that you end up having all these conditions that arise later on that is beyond your control.
Right. Well, that's great advice. Well, thank you so much, Dr. Schmeichel. I think that was everything on my end, but I learned so much, so thank you.
Well, now thanks again for the invitation, and we're always willing to share anything with your community. So if questions come up, please visit us at lowerfertility.com, and we'll try to follow up from there. Okay.
Thank you. Enjoy the rest of your day.
All right, you too now. All right, take care. Bye bye.